right? Of which diabetes features quite prominently. So we'll spend some time looking at diabetes in relation to the other components of the metabolic syndrome. Then we discuss prevention of complications, look at the experience here locally and how effective it has been in terms of diagnosing and treating with diabetes. And then there's a video at the end which I recently inserted that we'll look at regarding the ABCs of diabetes management. All right. So globally, WHO has estimated that the worldwide prevalence of diabetes in adults is around 422 million, and this was in 2014. What we have seen progressively is that the prevalence has been increasing and has nearly doubled since 1980, rising from about 4.7 to 8.5% in the adult population. And this reflects what we call an increase, or we've attributed this increase in prevalence to the increase in associated risk factors, such as overweight or being obese. Remember, we mentioned during the screening lecture that being overweight or obesity is a risk factor that leads to diabetes. And so, if you all recall, one of the ways that we can prevent is by using the concept of primordial prevention, where you seek to alter societal choices and enact policies and legislation, if possible, to prevent or reduce the incidence of risk factors, for example, obesity, which is quite notorious for putting people at risk for development of diabetes. Over the past decade, diabetes prevalence has risen faster in low and middle income countries than in high income countries, and diabetes caused 1.5 million deaths in 2012. Any ideas as to why I think diabetes has been more of a problem in relation to the low and middle income countries and not so much of a problem with the high income countries? Any thoughts about that? Why has the rate of increase been higher in these poorer countries? Healthy foods are expensive. Catherine says that. Yes, quite correct. So it's often easier to consume cheap obesogenic foods. Access to healthcare, yes. So you probably have less access to screening and for preventative and treatment of diabetes and its complications. Very good. Diet, yes. So again, back to things like the consumption of cheaper obesogenic foods, fast foods that tend to be more easily available and more affordable, right? Judy says education, yes. So education has to do with health promotion and disease prevention initiatives, which tend to be more advanced in higher income countries. And also the sort of physical activity that goes along with prevention strategies. So there may be policies, for example, in richer countries to allow for workplace gyms and time off to engage in physical activity and so on, more access to places to recreate, as opposed to less developed countries where that has not yet been established. And so these are some of the reasons why you'd find that the diabetes tends to disproportionately affect low and middle income countries, as opposed to high income countries where they've been able to make some strides towards reducing the incidence rates and prevalence rates as well. All right, so there's some facts about diabetes. So how do we classify it? But you all recall from the pathology and your other disciplines that looked at diabetes, there's basically two main types, type 1 and type 2. And we know that type 1 is due to autoimmune beta cell dysfunction of the pancreas, the cells in the pancreas. And this leads to an absolute insulin deficiency and causes diabetes to rear its head during childhood, and is often referred to as juvenile onset diabetes or insulin-dependent diabetes. Type 2 diabetes, on the other hand, is due to a progressive loss of beta cell insulin secretion on the background of insulin resistance. So you have this propensity towards hyperglycemia by virtue of the cells becoming more resistant to this endogenous insulin, and also your pancreas becoming less efficient in producing that insulin. And so by far, that is the most common of the types of diabetes. But what we found within recent times is that type 2 is beginning to become more and more diagnosed amongst younger people, even children, due to the overwhelming rates of obesity and overweight. There's also the entity known as gestational diabetes mellitus, and this has to do with diabetes that is diagnosed in the second or third trimester of pregnancy, and that was not clearly overt prior to gestation. So when you do your O1G rotation, you'll see that they screen all pregnant women for gestational diabetes, simply because diabetes is that prevalent in our country. And we have rates as probably as high as 1 in 5 or more being reported based on which studies you're looking at. All right, so you'll see that as a common cause in your obstetric rotation. And then there are specific types of diabetes due to other causes, things like monogenic diabetes syndromes, such as neonatal diabetes and maturity onset diabetes of the young or moody, diseases of the exocrine pancreas, such as cystic fibrosis and pancreatitis, and drug or chemical-induced diabetes, such as that associated with steroids use, and the treatment of certain diseases like HIV/AIDS or after organ transplantation. So by far the most common type being type 2, and the other types including type 1 and gestational diabetes. The metabolic syndrome is very important that we understand this syndrome because it encompasses a number of entities that go along with impaired glucose metabolism. So it really comprises the entities known as hyperglycemia, insulin resistance, dyslipidemia, hypertension, central obesity, and insulin resistance. And the features or the criteria for identifying the metabolic syndrome will look something like this. Men, well, there's abdominal obesity as evidenced by an excessive waist circumference. So in men, more than 40 inches or 102 centimeters, or in women, more than 35 inches or 88 centimeters. Then there are derangements in the lipid profiles, such that their triglycerides exceed 150 milligrams per deciliter, or equal to 150 milligrams. And there's HDL aberrations as well, where you tend to have a lower than usual HDL cholesterol, less than 40 milligrams per deciliter in men, and less than 50 milligrams per deciliter in women. If blood pressure tends to be elevated beyond 130/85, and there's also impaired fasting glucose, usually more than or equal to 110 milligrams per deciliter. All right. In terms of screening, it is not recommended to use urine as a screening test. Rather, the fasting plasma glucose is the recommended screening test to be used. And so that really involves drawing a blood sample, a venous sample from an overnight fast, and then having it reported on by a calibrated machine. Blood glucose tested by glucometers, what we locally refer to as diascans, may play a role in initial screening, but cannot be used for diagnosis. So sometimes, because in the field it might be difficult to have a venous sample processed in a laboratory, you'd find that they would use sometimes doctors use these diascan machines, and they help in screening, especially if you get very high values. But by right, the approved screening test is the fasting plasma glucose based on a venous sample drawn after 8 hours of fasting without any caloric intake. Right. So this is the diagnostic criteria. Note that there are a number of criteria that can be used. One is if you have a fasting plasma glucose greater than or equal to 126 milligrams per deciliter. Fasting meaning there's no caloric intake for the last 8 hours. or you can have your 2-hour post-load glucose test. So what happens is that you have the patient, after having fasted overnight, consume 75 grams of anhydrous glucose dissolved in water, following which first a fasted plasma glucose is drawn. They consume the 75 grams of anhydrous glucose dissolved in water, and then 2 hours after, another blood draw occurs, and if this glucose reading is above greater than or equal to 200 milligrams per deciliter, that is diagnostic of diabetes. Also, in a patient with classic symptoms of hypoglycemia, which would be things like what? Polyuria, polydipsia, right? Weight loss, right? Polyphagia, and so on. If you have symptoms, overt symptoms of diabetes or hyperglycemia, and your random sugar or random plasma glucose is greater than or equal to 200 milligrams per deciliter, that is also diagnostic. Note that the hemoglobin A1C has recently been approved for diagnosis, and this is really a marker of how much glucose is attached to the red blood cells. And red blood cells generally last between 90 to 120 days. So it gives us a pretty good interpretation or estimation of how much sugar has been circulated in the blood within the last 3 to 4 months. And if it is that your hemoglobin A1C exceeds 6.5% in a lab that is standardized, this also is diagnostic of diabetes. All right. Any questions about screening and diagnosis of diabetes so far? All right, we'll press on. So these are the diagnostic criteria here. Categories of increased risk of future diabetes. So, there are some results that wouldn't be able to allow you to diagnose overt diabetes. But if you were to get the following readings, then you would fall into one of these categories. For example, if your fasting plasma glucose came in between 100 and 125 milligrams per deciliter, that would put you into the impaired fasting glucose category or pre-diabetes category, which confers a greater risk than the general population for the development of subsequent diabetes. If your 2-hour plasma glucose following that 75 grams of glucose ingestion comes in between 140 and 199, this places you in the entity called impaired glucose tolerance. And this is also a feature of prediabetes and puts you at risk for subsequent development of diabetes. If a hemoglobin A1C is between 5.7 to 6.4, just short of that 6.5% diagnostic threshold, you'd find that that puts in the category of elevated hemoglobin A1C, which is also part of this prediabetes range, conferring a greater risk for the subsequent development of diabetes. All right, so these are little gray areas here that are defined, put you into these categories, but essentially what they do is render you pre-diabetic and at risk for development of diabetes, and therefore you would require some intervention, usually in the form of lifestyle advice, but sometimes even medical therapy. So we'll chat about that a bit later. All right, so how do we treat with this problem of diabetes in terms of what are we to do at the initial visits and the follow-up visits, and how do we manage it, not only in not in isolation, but in relation to the other components of the metabolic syndrome, vis-a-vis your blood pressure, your lipids, and so on. All right, well, these are sort of target ranges that we want to achieve in treating diabetes holistically. All right, so when we get into the therapy and the lifestyle advice, we'll flesh out the exact treatment options. But these are the sort of target ranges we would set our diabetic patients in relation to these metrics here. So in terms of your blood glucose, I mean, surely some of you all would have diabetic friends or relatives. We would want their preprandial or before meal sugars to be between 90 to 130 milligrams per deciliter. And if they ate a meal, it really shouldn't exceed 180 milligrams per deciliter. We'll want to see the A1Cs less than 6.5%. Now, sometimes with older relatives and so on, you'd find that physicians or endocrinologists might carry up that range to 7 or 7.5%. And the reason really is that because older patients tend to have a propensity towards becoming hypoglycemic, and the sort of life-threatening complications that can ensue with hypoglycemia, they tend to give a little more leeway and are satisfied with A1Cs less than 7 or 7.5. But for the majority of your diabetics, we want to see that A1C in the range of less than 6.5. In terms of your total cholesterol, you'd want that to be less than 200 milligrams per deciliter. You'd want the HDL cholesterol to be more than 40, the LDL cholesterol to be less than 70, and your triglycerides to be less than 150 milligrams per deciliter. You'd want your blood pressure to be less than 130/80. We know that diabetics are at increased risk for macro and microvascular complications. Things like diabetic retinopathy, nephropathy, neuropathy, and so on. And the lower your blood pressure is, especially in patients who have diabetes, the less likely you are to succumb to these macrovascular complications like strokes and MIs and so on, and the microvascular complications like retinopathy and nephropathy and so on. We'd want the BMI to be within the normal range, 18.5 to 25. And in terms of the waist circumference, we would generally want women to have a waist circumference less than 32 inches, and men to have a waist circumference less than 37 inches. Note that if you're East Indian or Chinese, because these two groups have a greater propensity genetically and ethnically towards diabetes, especially that based on their abdominal obesity or propensity to gather weight around the abdomen, we'd want them to have, the men at least, to have a lower than 35-inch waist, because studies have shown that if you exceed that, that increases the risk for development of diabetes. All right, this slide here is a bit cluttered. I won't say cluttered, but it's a bit extensive, and we'll see how best we could break it down. It speaks to what it is that needs to be done at initial follow-up and annual visits. So when you see a diabetic patient for the first time, there are a number of things you need to assess. It's a consultation that would take a good bit of time, and you need to go through these different areas to be complete in your assessment. So in terms of a history, you want to find out about the onset. Was it something insidious or something that occurred suddenly? So for example, type 1 diabetes, they tend to have a more acute onset because remember their presentation is due to the absolute deficiency of insulin. So the child, usually it's juvenile onset, these children will present quite dramatically with polyuria, polydipsia, maybe even a diabetic coma, and they tend to be ketotic because of this absolute deficiency of insulin, and so they can present comatose or semi-comatose, as opposed to the type 2 diabetic patient who may describe a more insidious type of onset of symptoms. Things like nocturia, unintended weight loss, recurrent yeast infections in women. They may even say that they have their urine contains more sugar than usual, and they might know that if they're testing it at home, or they might even get a scent, or even some patients might tell you that they spilled urine and then they see ants around the toilet and so on. So these are little subtle signs rather than something quite dramatic like the type 1 diabetic. This is how they would tend to present. You review any previous treatment regimes that they might have been prescribed and their response to treatment, assess and ask about any previous hospitalizations. Of course, very important to inquire about the family history. We know that diabetes is a strong genetic component. It also tends to ethnically favor East Indians as opposed to Africans. But both groups, because of their lifestyles, are at increased risk based on the data we've seen in Trinidad. So you want to find out about first-degree relatives having diabetes, autoimmune disorders, probably more of an issue for type 1, but certainly family history of diabetes, very relevant for type 2. Personal history of complications and common comorbidities. So you'd ask about micro and macrovascular complications. Remember we spoke about things like heart attack, strokes, retinopathy, nephropathy being more common in diabetes. Common comorbidities. There's an association between diabetes and obesity. Also obstructive sleep apnea. And that's kind of correlated with the obesity, where you tend to have a lot of fat around the truncal area and the neck and so on, sometimes causing closure of the airways and sleep apnea at nights amongst obese patients. There's also a strong correlation between sleep apnea and resistant hypertension, where you'd find that patients who have sleep apnea, some of them prove quite difficult to have their blood pressures controlled. You also want to ask about hypoglycemia. Has there been any instances where the blood sugar dropped low? When has this occurred? How frequently are the patients aware when their blood sugars go low? Because sometimes that could be silent, and in the absence of overt signs and symptoms like tremulousness and hunger and cold sweating and so on, the patients could progress rapidly into coma. So you want to find out about hypoglycemic awareness and episodes. Any prevalence of hemoglobinopathies or anemias, very important in our population, because we have a large population with sickle cell and thalassemia traits and diseases. And the problem with that is that those hemoglobinopathies, the blood cells tend to have a shorter lifespan. And so that has implication as it relates to the accuracy of A1C testing and so on. So those hemoglobinopathies, you need to be careful if patients do have them as to how you would interpret the A1C level. All right. Of course, other things like your blood pressures, your lipid profiles, dentition, eye exam for retinopathy, and even specialists and so on. Those are things that need to be explored. All right. Interval history, changes in the medical family history since the last visit. And very important here, your lifestyle factors. Remember, diabetes is a lifestyle disease, and is due to a combination of unhealthy eating, sedentary lifestyles, and other poor lifestyle choices. So you want to find out about the patient's eating patterns. What do they eat? How frequently do they eat? Is there an adequate intake of fiber, or is there an excess of highly caloric foods, starchy foods, and so on? Their weight history, what has been their weight over the course of the last few months and years? How physically active are they? Are they getting sufficient sleep? There's evidence to suggest that shift work and reduced sleep, less than 6 hours of night rest, is associated with increased risk of diabetes. And do they also consume substances, in particular tobacco? Cigarette smoking is associated with increased risk in diabetes. So is excessive alcohol or unhealthy use of alcohol. In terms of medications and vaccinations, they want to find out what currently are the medications they have been on. There's drug-induced diabetes, particularly certain HIV/AIDS medications, and corticosteroids. Oral corticosteroids can increase the risk of diabetes. Their medication to taken behavior that really speaks to compliance and reasons behind it. is there any medication intolerance or side effects? Are they using any complementary alternative medicines? Are they currently up to date with their vaccinations? In terms of technology used, most of the times you want to ask our patients, are they using these diascan machines to self-monitor their blood glucose, and what has been their experience with it in terms of their readings pre and postprandial. And also very important are things like psychosocial conditions. There's a lot of evidence that chronic diseases, there's a high correlation or comorbid mental health illness associated in the form of diabetes, form of depression and anxiety. And you'd want to screen using some of the tools that you might encounter in primary care or in psychiatry, such as the PHQ-2 or the PHQ-9, because these ultimately impact on your glycemic control, especially in depressed patients who may be poorly motivated to embrace the lifestyle changes required or comply with medical therapy that is required to control their diabetes. All right. So this is an important slide to look at, and it tells you what to do in initial visits, follow-up visits, and annual visits. All right, in terms of the physical exam, well, you do some body demographics, height, weight, allow you to calculate your BMI, blood pressure. You need to take it lying and standing, right? Sometimes diabetics suffer from something called autonomic neuropathy. You might have heard of it. It damages the autonomic nervous system, and so you have that sort of loss of or I should say not loss or reduced blood pressure when the patient stands up, because the autonomic nervous system normally counters that by enabling patients to sustain their blood pressures. But sometimes people with long-standing diabetes could have postural hypotension where their blood pressure gets low when they stand up. Of course, fundoscopic examination to look for signs of diabetic retinopathy. Thyroid palpation, you want to make sure that the diabetes isn't correlated with thyroid dysfunction. So sometimes, disorders like Graves' disease and so on can cause aberrations in their glycemic control that need to be considered when you treat these patients. Examine the skin for something called acanthosis nigricans. This is a telltale sign or a pretty common sign of insulin resistance. And it looks like a darkening of the skin, particularly around the neck or under the axilla. And it is a velvety appearance that is really pathognomonic of insulin resistance. And it could also get it in carcinomas of the GI tract. But you'd probably see it in a lot of obese individuals who are diabetic or pre-diabetic, and it's also associated with skin tags and so on. All right. You want to look at insulin injection sites, because sometimes they suffer from something called lipodystrophy. So if you repeatedly inject insulin into the same site, you'd find that the skin becomes, or the subcutaneous tissue becomes quite hard and becomes less efficient at absorbing insulin. And the way they counteract that is by asking patients to rotate the sites at which they administer insulin, so it doesn't become prone to becoming lipodystrophic. Right? And also need to perform a comprehensive foot examination. Surely you all might have heard of diabetic foot ulcers and diabetic feet, where by virtue of the neuropathy associated with diabetes and also compounded by the macrovascular peripheral artery disease, you have diminished blood supply and circulation and sensation, rendering the foot susceptible to damage and ulcers. And so you need to always assess the feet of your diabetic patients for the skin integrity, deformities, callus formation, the pedal pulses, temperature, vibration, and soft touch. Right? So these are important exams you need to perform on a diabetic patient. In terms of your lab indices, A1C is really your best measure, especially if the patient doesn't have any comorbid hemoglobinuropathy, to tell you how well the glycemic control has been in the preceding 3 months. So this should really be done every 3 to 6 months. And those patients that you're seeing for the first time and following up closely to establish control, if they are well controlled, it probably can be done just once or twice for the year, but in the initial instance, every 3 to 4 months. And the initial visit, and then thereafter yearly, you'd want to order a lipid profile, liver function tests, your urine albumin to creatinine ratio, which gives a marker of early nephropathy, right? So even before frank proteinuria becomes picked up on a urine dipstick, you begin to pick up microalbuminuria or small quantities of albumin in the urine by doing these spot urinary albumin to creatinine ratios. And if you pick up that, then you could try to avert the full consequence of nephropathy by instituting the appropriate treatment. All right. You also want to do your creatinine and EGFR, another renal assessment parameter here. Thyroid stimulating hormone, especially in patients type 1 diabetes, to look for hypothyroidism and Graves' disease. Vitamin B12 levels indicated sometimes, especially for patients on metformin, because they've shown that metformin can render some patients B12 deficient. And serum potassium levels in patients on certain antihypertensives like ACE inhibitors, angiotensin receptor blockers, or diuretics, which can cause hypokalemia as a complication. All right, so these are the sort of questions you want to ask in the history, the sort of examinations you want to perform in the physical exam, and the sort of lab tests you want to be done initially and then annually. Any questions about the history, physical exam, or lab test that we need to order? All right, if no questions about those parameters, let's move on. Sorry. All right. Remember, students, that lifestyle measures, principally changes in nutritional habits and physical activity, may reverse some of the lipid, glucose, and blood pressure disorders of diabetes. So it's very important, like with asthma and most chronic diseases, to have some measure of lifestyle change. So we saw in asthma how important it is that we control the environment as far as possible by avoiding triggers. Similarly, in diabetes and hypertension and the metabolic syndrome by extension, it's very important that we seek to adjust our diet and exercise regularly. The reason for that being is that these sort of lifestyle changes can actually reverse some of the disorders associated with the blood glucose and lipid that form part of the metabolic syndrome. So it is entirely possible for somebody who is diabetic or pre-diabetic and highly motivated to make those changes to be able to reverse some of the measures of glucose, lipid, and blood pressure parameters, and therefore, not be classified as being diabetic or pre-diabetic. If, however, the patient lives long enough, invariably they will become diabetic, but the evidence has shown that lifestyle changes can sometimes suffice in reversing the pathology that has taken place and render you normal glycemic by virtue of the parameters we measure, like your blood sugar levels. And you can also have favorable changes on your blood pressure and lipid levels. So lifestyle advice would feature as paramount in any algorithm that deals with the treatment and management of diabetes. So let's speak about this lifestyle management. It is a fundamental aspect, and we can't underscore that enough in diabetes care. and includes diabetes self-management and education and support, DSMES, medical nutrition therapy, physical activity, smoking cessation counseling, and psychosocial care. Patients and care providers should focus together on how to optimize lifestyle from the time of the initial comprehensive medical evaluation, which we just went through, throughout all subsequent evaluations and follow-up, and during the assessment of complications and management of comorbid conditions in order to enhance diabetes care. So what this slide is saying here, students, is basically throughout the entire spectrum and the entire period for which you will follow up your diabetic patient, you need to reinforce and focus on the entities that comprise lifestyle management. All right, so the self-management education, the support, the medical nutrition therapy or dietary advice, the need for them to exercise most days of the week, 30 to 40 minutes each time, preferably aerobic exercise. They need to not smoke, and if they do smoke, to try and quit the habit, as we discussed last week. And psychosocial care, meaning, to always screen for mental health issues and look at social issues that might be compounding their condition as it relates to things like poverty and access to care and so on. So this slide is, well, very wordy, could be somewhat confusing, and especially for having just being your first rotation, we need to just take it a bit slowly and in the context of what is most important to extract here. So this is the most sort of evidence-based medicine algorithm or framework as iterated here by the American Diabetes Association to treat diabetes from a pharmacological perspective. Now, this is separate and apart from the lifestyle advice that you need to give every diabetic patient, but sometimes, or I probably should say most times, lifestyle interventions are not enough, and we need to assist the patient in some form of therapy. So we'll see based on this algorithm here that first-line therapy across the board is a drug called metformin, and this goes hand in hand with your lifestyle advice, that is weight management and physical activity. And the patient is followed up usually with a A1C, and if this A1C is above goal, then we proceed to select one of the options or one or more of the options indicated in these parts of the algorithm here. But by far and across the board, metformin and lifestyle changes are first line. Anybody have ever heard of the drug metformin or glucophage and knows what type of drug it is and how it works? All right, so metformin, known as by the brand name glucophage, is a class of drug belonging to the biguanide group of drugs. And the way it works is really by reducing insulin resistance. Yes, that is correct, Daniela and Annalise. But primarily by reducing gluconeogenesis from the liver. So basically what it does, it reduces the hepatic output of glucose and at the same time sensitizes peripheral tissues, in particular skeletal muscle, to the circulating insulin to help increase glucose uptake. And so it's a very important drug. And what is very useful about this is actually that it promotes weight loss. So it's complementary in that regard, especially for type 2 patients. And therefore, you'll find that in the absence of any contraindication to metformin therapy, almost all type 2 diabetics are on metformin. And it is usually taken twice a day with meals to reduce its major side effect, which is gastrointestinal upset and diarrhea. So it's usually taken with meals, and it's quite useful for promoting weight loss. So metformin with lifestyle intervention here is first line. And then if that fails to achieve an adequate A1C, which is usually less than 6.5%, then we need to look at whether or not the patient is a chronic kidney disease patient or a patient with established atherosclerotic cardiovascular disease. And if it is, they don't belong to either of those two categories. That is, they don't have chronic kidney disease or established atherosclerotic cardiovascular disease. Then your choice of therapy is along one out of these three subgroups here. In Trinidad, you'd find that at least in the public system, cost is usually prohibitive, and that we in the public system through CDAP or through the formulary would prescribe another drug, usually of this class, called the sulfonylurea. Have you heard of sulfonylureas and know of any examples of those types of drugs and how they work? So sulfonylureas really are secretagogues, or they really cause the pancreas to increase the secretion of endogenous insulin. But by virtue of doing that, they can increase the risk of weight gain and hypoglycemia. So they could be quite dangerous in that regard. So you have to be careful when you start patients on a sulfonylurea, something like gliclazide or glimepiride, that you counsel them about the potential for hypoglycemia and weight gain. So those are usually type of drugs that would be selected when there's also a class known as the diones. They are also cheaper, and they can sometimes be used. They also increase insulin secretion, but can exacerbate heart failure, and you have to be careful with those. But they tend to be on the cheaper end. So you'd find that most of our patients would be on metformin plus or minus a sulfonylurea. Now, if students, there's a company need to minimize weight gain or promote weight loss, there are two newer classes of drugs which are sort of weight neutral or can in fact promote some weight loss. And these are called the GLP-1 receptor agonists. And there are particular subclass that with a good efficacy for weight loss, or the SGLT2 inhibitors, right? So somebody mentioned incretin analogs. Daniela, is that what, are you seeing that class of drug depicted here? What does that relate to? Yeah, so that's really a GLP-1 or glucose-like peptide-1 receptor agonist, which really, because it exerts its effect on the gastrointestinal system, and it causes your body to produce less glucagon and more insulin in response to the carbohydrates that are in your gut. It is less, because it only responds to when they have carbohydrates in the gut or food in the gut, it's less likely to cause excessive insulin secretion, and therefore less likely to promote weight gain. All right, so that's how those drugs work. There's also one called the SGLT2 inhibitors. You all know how they work. And what organ do they exert their function? Yeah, so Shari is correct. They work at the kidney. So they basically block the glucose transport 2 receptor. Now, you know that some glucose is filtered through your kidney. So your kidney can either reabsorb it or excrete it. And so when you block this SGLT2 receptor, in effect, what you're doing is you're blocking the reabsorption of glucose, thereby promoting its secretion, or excretion, I should say, through the kidney. So basically, you're peeing out your sugar, and so that would tend to promote weight loss, because you're excreting excessive calories. The problem with that is that they could probably develop urinary tract infections or yeast infections because your urine becomes quite osmolar, hyperosmolar, by virtue of excreting these excessive calories, right? So those are two classes of drug you could consider when you want to minimize weight gain or promote weight loss. Now, the SGLT2 inhibitors, they are given orally, but the GLP-1 receptor agonists, they are given subcutaneously, right? So Caviar is given us an example. They have empagliflozin, which is a SGLT2 inhibitor, and it causes urine glucose to flow out, as Daniela is quite rightly saying here. Now, if there's a need to minimize hypoglycemia, remember I made the point that, like the older people, you tend to find that we relax the A1Cs, and we tend not to be as stringent because they have a propensity towards going hypo, and we won't want them to go hypo and go into comas. So if you want to select a class of drug where you're least likely to go hypo, you'd want to select any of these groups here. Your GLP-1 receptor agonist, or your SGLT2, as we discussed before. But there are another class called the DPP-4 inhibitors, dipeptyl peptidase 4 inhibitors, and they work a little bit similarly to the GLP-1 receptor agonists. They can be given orally. They are not injectable. They are also cheaper, less, and don't have many side effects. Certainly hypoglycemia is not one of them. And so they are quite useful for patients who you don't want to go hypoglycemic, right? So you have DPP-4 and also thiazolidinediones, as we saw here in this part of the algorithm, where they are also cheaper and less likely to be associated with hypoglycemia. All right, so these are the sort of options you have available in these subgroups here. Know that if it is that the hemoglobin A1C is still not at target levels, you can use classes from other drugs from different classes, right? And once they're not contraindicated, you can continue adenine therapy. But you'd find that if it is that your combinations fail to work, then ultimately you may be looking at starting insulin. All right. Yes, the DPP-4 inhibitors can increase the risk of pancreatitis. That is true. All right. Now, in patients that have established atherosclerotic cardiovascular disease, heart disease that is, or peripheral artery disease and so on, or chronic kidney disease, so basically where you have macrovascular and microvascular complications, you want to be a bit careful, and based on the evidence, if it is that you have atherosclerotic cardiovascular disease predominating, you would want to choose a GLP-1 receptor agonist or an incretin analog with proven cardiovascular benefit, or SGLT2 inhibitor with proven cardiovascular benefit once your GFR is adequate. In other words, once you're not in renal failure. All right, these would be your options here. Or if it is you have heart failure or chronic kidney disease predominating, you would want to choose a SGLT2 with evidence for reducing heart failure, like canagliflozin, or one that reduces chronic kidney disease progression. Or if you don't go with one of these, then you'd want to use a GLP-1 receptor agonist with proven cardiovascular disease benefit. Right, so those are really your two classes of drugs here. I don't want to confuse you all because there are quite a large number of classes of drugs that can be used, but just to simplify by saying that these are the preferred agents when you have a complicated diabetic in the form of atherosclerotic cardiovascular disease, heart failure, chronic kidney disease, being a comorbid condition against the backdrop of diabetes. All right. Any questions about the algorithm? I know it could be quite a lot to take in on first glance, but if you follow it down, it becomes quite easy to understand, knowing that you can add or substitute different classes of drugs when therapy fails to attain a target A1C. Yes, so Daniel has asked me if drugs added to metformin. So you remember metformin is first line and standard in the absence of any absolute contraindication to it. Right? Contraindications would be like if a patient has lactic acidosis and so on, or severe chronic kidney disease, grade 5 and so on. But metformin is across the board. So the drugs are in addition. Right, so Annalise is asking if there is insulin resistance, why is insulin considered a treatment option? Wouldn't it make the insulin resistance worsen over time? Remember, the insulin resistance is really the insulin that we produce endogenously. So the body is becoming resistant to our own insulin. Remember, the insulin that we inject is exogenous insulin derived from a different source. And therefore, the body hasn't demonstrated any insulin resistance in that regard, right? So it won't make the insulin resistance worsen over time, if that's what you're asking. If the patient is asking if the patient has no comorbidities but has a strong family history of cardiovascular disease, can these drugs be beneficial before cardiovascular disease, heart failure, or chronic kidney disease? No, Elena, yeah, so even a family history of cardiovascular disease doesn't impact on your choice because it has to do with whether or not you have established that is established for the patient, not in terms of family history. So it doesn't really bear on that family history of comorbid conditions. I have a question. Daniel is asking, considering antibiotic drug, why are oral antibiotic drugs contraindications in patients undergoing surgery or suffering from severe illness? Right. So we'll get to that shortly when I look at the indications for insulin. So I'll answer that question when we look at indications for insulin therapy. You'd find that insulin is tend to be used at times of surgery or severe illness like myocardial infarctions, simply because during those times you could get aberrations in your kidney function that can alter the pharmacodynamics, kinetics, like the excretion and so on, erratic, and could cause hypoglycemia. So insulin gives you a better level of glycemic control for these periods when the body is under stress from surgery and acute illness, right? Because you're able to alter the dose and provide better glycemic control under those conditions. All right, this slide here, really, you can review in your own time, go over it. It goes through the different classes of drugs here and speaks to its main cardiovascular effects, changes that may occur with respect to your weight, hypoglycemic risks, efficacy, renal effects, and additional considerations. So you'd find like metformin is contraindicated when the eGFR is less than 30. So basically, if you have stage 4 and 5 chronic kidney disease, that's an absolute contraindication because it can increase the risk of lactic acidosis. All right, so we'd find that in the absence of that contraindication, that metformin is pretty standard unless the gastrointestinal side effects are intolerable. And that can usually be worked out just by asking the patient to take their metformin with meals or by using a different brand of metformin. All right, so I want you all to go through the different classes of drugs, and become aware of when they might be more useful and some common indications and contraindications for them. But know that you'll explore these in much greater detail in your meds therapeutics rotation. And my job today is not really to go into detail about each of these drugs and when they're indicated, but simply to kind of familiarize yourselves with it. All right, so we're going to move on. Right, so who gets insulin? So somebody asked the question why it is more beneficial or why they shouldn't be given oral hypoglycemics or oral agents in surgery and when somebody is very ill. Well, to start with, all type 1 patients will get insulin because remember, type 1 diabetes is an absolute deficiency of insulin that we're dealing with. Patients with elevated A1Cs despite adequate therapies, so if you've exhausted your oral agents and you've determined that they have optimized their lifestyle changes and have been fully compliant with therapy, then by virtue of not being successful with the oral agents, you'll have to proceed to have them switch to insulin. To cover acute illness, surgery, or pregnancy, because oral hypoglycemics are not really safe in pregnancy, you have no choice but to use insulin, preferably in pregnancy. And illness and surgery, because these are stressful conditions and can cause aberrations in your blood sugar profiles, the kidney function, and otherwise, it is safer to use insulin to treat diabetes. For example, when you have an acute illness or infection and you require hospitalization, or acute illness like an acute myocardial infarction, you tend to find that those patients are treated with insulin, or sometimes something called a sliding scale insulin, where the nurses monitor their blood sugars throughout the course of the day and titrate their blood sugars by giving different doses of insulin in accordance with a prescribed scale by the physician. Of course, the treatment of DKA or diabetic ketoacidosis, which is a life-threatening condition, you need to use insulin in order to treat with the acute setting of dehydration and possible hyperkalemia and hyperglycemia. Insulin is best to treat with those entities in regard to that life-threatening condition there. All right, so these are people who get insulin. All right, there are different types of insulin. They have rapid acting, long acting, and so you'd find that commonly the ones we would prescribe will be short acting R insulin, intermediate or N insulin, long acting like Glargine or insulin Lantus, and sometimes in CDAP or in the hospitals, you'd find a pre-mixed insulin in the form of a 70-30 or 80-20 mix, with 70 lente or intermediate acting and 30% irregular. And they really have to do with how long insulin stays in the body after it's administered. So short-acting insulin, like insulin R, would stay a couple of hours. Rapid-acting would just stay a matter of minutes, less than an hour, and be metabolized and no longer acting after a short period of time. Intermediate acting will act a bit longer, in a region of about 6 to 12 hours. Longer acting could act throughout the day, 18 to 24 hours. And premixed insulin is one that physicians tend to use a lot because it gives you that combination between intermediate and regular and short acting. So it's able to provide that level of glycemic control by having a short acting part of it, so that it counteracts the hyperglycemia when someone consumes a meal, and then gives you the longer acting or intermediate coverage for a few hours after they would have consumed the meal. So in effect, you have a combined regular and intermediate in one dose of insulin, but with a split 70-30 or 80-20 mix. So you'd find that people on insulin can be both on insulin and oral agents. Typically, you'd find that most type 2 diabetics who are on insulin would also be on metformin by virtue of metformin being first line. But it's not unusual. You could also find them on sulfonylurea, metformin, and insulin if they haven't achieved that desired level of control. Sometimes you'll find them on twice daily regimen of both regular and NPH insulin. So different quantities of R and N insulin morning and evening. Or they may actually be, or they could be on this RNN in a premixed form, this 70-30 that a lot of diabetics tend to be placed on. Or they can be on a multiple dosing regimen, rapid acting with each meal and long acting insulin. Some people, some diabetics, have this problem where their blood sugars spike when they consume meals. And you'd find that the only way that the physicians are able to control that spike is by having a rapid acting or very short acting insulin like Epidra given at the same time as the meal, and then longer acting insulin like Glargine or Lantus to give them the control over a longer period of time. So these patients may be sticking themselves as many as 2-3 times a day, depending on how many meals they have, because they need to get the rapid acting insulin on top of that long acting insulin or basal insulin like Glargine or Lantus. So how do we actually go about starting insulin therapy? Well, generally, you'd find that, for example, if you're going to use a long-acting insulin like insulin Glargine, you would use, start with 10 to 15 units for most adults once a day. We titrate up until we get their fasting sugars at about 100 milligrams per deciliter. So what this really means, students, you could just start with the long acting at about 10 units and ask the patients to record their fasting sugar. And if 10 isn't enough on the 1 and 2, they go up to 12 and then to 14 and so on until they get their fasting sugar to be in the region of about 100 milligrams per deciliter. However, because the long-acting insulins like Glargine or Lantus are quite expensive, cost is often prohibitive. And so you may need to use the N and R insulins, N being intermediate and R being the short-acting, which might be available on formulary or on CDAP to be able to achieve glycemic control. So basically, you would want to begin using NNR in this manner. Most adult patients would require about 45 units per day, depending on if they're average size, but you could work out the total insulin requirement based on weight by using a general dose of between, say, 0.1 or 0.2 units per kilogram. So let's say someone weighs 70 kilograms, then if we multiply 70 by 0.1, we will get 7 units of insulin per day, and that might relate to, I should say rather, that 0.1 or 0.2 really speaks to the long-acting insulin. But the twice daily, generally you'd find that most average size adults would require between about 30 to 45 units a day or more. But the way in which you split up the dose into AM versus PM or morning versus evening is as follows. Regardless of the start with, and in this case I just given 45 minutes as an example, 2/3 of that quantum has to be delivered in the morning time and 1/3 in the evening time. The reason being is that most patients, probably save and except for shift workers, would tend to consume most of the meals during the day and therefore have higher blood sugars during the day because they respond based on the food that they take in. So the greater quantity, 2/3 of that daily dose is given in the morning, and a third is in the evening. So 2/3 of 45 is 30 units, and a third of 45 is 15. And then we apply the same 2/3, 1/3 rule to split it up based on the type of insulin. Remember, the N insulin or the NPH insulin is the intermediate acting, the one that would give you around 6 to 12 hours of coverage. And the regular insulin is a short acting that would give you between 1 to 2 hours. So we would want the greater quantity of insulin to comprise the intermediate acting in the form of N insulin in the same 2/3, 1/3 ratio. So of the morning dose of 30 units, you would want 20 to be N and 10 to be R. Similarly, for the evening dose, you would want 10 or 2/3 of that 15 to be N, NPH, and 5 out of that 15 or a third to be R. So that 2/3, 1/3 really versus evening, with the greater portion thereof in the morning, 2/3, and then the 2/3, 1/3 also relates to the type of insulin, with the 2/3 or the greater portion being given in the form of the intermediate acting, and the smaller portion in the form of a third given in the shorter acting or R insulin. Any questions about insulin therapy and how we initiate it? So here we usually, for the long acting like the basal, glargine or Glantus, we would use 10 to 15 units based on the formula of 0.1 to 0.2 units per kilogram per day. But the R and N is usually based on an average size adult, and usually starts with about 45 units. For the smaller or leaner person, you might start with 30 units, but regardless of whatever quantity you start with, it has to be disaggregated in this manner: 2/3, 1/3. All right. Let's look at diabetics who also have hypertension. And we know based on the metabolic syndrome that that is more likely to happen along with lipid disorders or dyslipidemia. So basically, you'd want to look at it within the context of their blood pressure reading. If their blood pressure is less than 160/100, it's likely that they might just require one antihypertensive. If, however, their blood pressure is greater than or equal to 160/100, they may more than likely require 2 or more agents. Note that lifestyle management is common to both entities here. So regardless of your blood pressure, you must counsel them on diet and exercise. And with a special reference to high blood pressure, you'd ask them to reduce their salt intake as well, because that is also associated with an increased risk of high blood pressure or hypertension. And you'll have a session with Dr. Clapperton, and she will speak to hypertension at length. But I'll just go through this algorithm here. So if their blood pressure is less than 160/100, you'll start one agent, the choice of which depends on whether or not the patient has protein in the urine, as evidence of by albuminuria. So if they're spilling protein in the urine, we'd want to select an ACE inhibitor or angiotensin receptor blocker, because these are shown to be renoprotective, and therefore those would be your drugs of choice. If they're not spilling protein in the urine, you could use any of the following: ACE, ARB, calcium channel blocker, or diuretic. Now, a patient who has a blood pressure, diabetic patient, I should say, who has a blood pressure is in excess of 160/100 and has needs to be started on 2 agents. If they are also having protein in their urine, you need to start either ACE inhibitor or angiotensin receptor blocker, and combine that with either calcium channel blocker or diuretic. If they're not spilling protein in their urine, you could choose 2 out of any of these 3 options: the ACE or ARB, calcium channel blocker, or diuretic. After you've started on these medications, you review them by assessing their blood pressure and the presence or absence of any side effects. And then you continue adding agents in this direction until you achieve blood pressure control. Remember, with diabetics, you really want to achieve a blood pressure in the region of 130/80 or less, because the higher blood pressures are on the background of diabetes, the greater risk of macro and microvascular complications. All right. Now, if you fail to achieve blood pressure control using these agents here, sometimes you need to confer with a specialist, or even start adding drugs like mineralocorticoid receptor antagonists like aldactone and so on. All right. But I find that the majority of patients would be have their blood pressure control using one or more of the agents described above here. Any questions so far about insulin or blood pressure control on the backdrop of diabetes or amongst diabetics? Okay, not as yet. All right, let's pressure on then. All right, lipid management, remember, also a very important component of the metabolic syndrome. Diet and exercise still remain the cornerstone of treatment of dyslipidemia. So basically, when you counsel them on diet, what you tell them to avoid things like red meats, saturated fats, trans fats. So basically, avoiding processed foods, avoiding fried foods, things like cakes and pastries, and substituting them with more healthy options like fruits and vegetables. All right, preferably grilled and not fried. That sort of advice in terms of diet. Exercise, we went through that already. Pharmacological therapy is often required to targets HDLs in excess of 40. We want the total cholesterol to be less than 200. We want the LDL to be less than 70. So very often you'd find that in diabetic patients, they place on drugs like statins, which are HMG-CoA inhibitors. So they reduce the endogenous production of cholesterol. Right? And therefore, you need, because we know that dyslipidemias are so common amongst diabetics, we want to screen all diabetic patients for dyslipidemias by having lipid profiles and thereafter yearly lipid profiles to monitor their lipid constituents. Right, so LDL cholesterol, if you find that the patients are having high LDL cholesterols, statins are usually drug of choice, and they want to bring the LDL to less than 70 preferably. If HDL cholesterol tends to be the issue where they're having persistently low HDL cholesterols, there's good evidence for niacin or nicotinic acid, which is a vitamin B derivative, to raise your HDL cholesterol above 40. For patients that have an issue with triglycerides or hypertriglyceridemia, you want to advocate for calorie and alcohol restriction, tight glycemic control, and sometimes the institution of fibrate therapy in the form of gemfibrozil if the lifestyle measures fail. Who gets aspirin is often a subject of contention. So we use aspirin therapy in a dose of 75 to 162 milligrams per day as a secondary prevention strategy in those who with diabetes and a history of atherosclerotic cardiovascular disease. In other words, if it is that they had established cardiovascular disease by virtue of having a previous MI or having symptoms like angina, certainly aspirin is warranted. So for patients with atherosclerotic cardiovascular disease and documented if you can aspirin, you could use Plavix or clopidogrel, but certainly aspirin is indicated for those patients. Dual antiplatelet therapy, that is aspirin together with a drug like clopidogrel, is reasonable for a year after an acute coronary syndrome, such as an MI, and may have benefits beyond this period, but it may also have risk. So sometimes patients ask if they need to be on both aspirin and Plavix after an MI. The answer is yes, but just for a year. Beyond that, it may be beneficial, but it can also be harmful because it increases your propensity for bleeds or bleeding. Aspirin therapy may be considered as primary prevention in those with this diabetes who are at increased cardiovascular risk, after a discussion with the patient on the benefit versus increased risk of bleeding. So what they're saying here, students, is that generally speaking, it is not of benefit to most patients who never had heart disease or who are not at high risk for complications. But if you deem the patient to be at increased risk by virtue of doing some sort of risk stratification tool like your Framingham score or other tools that stratify your risk for heart disease within the next few years, if you deem their risk to be unacceptably high, say for example greater than 10%, it is reasonable to start them on aspirin in the form of primary prevention. But generally, if you're not at increased risk or you don't have any increased risk being demonstrated by application of a risk assessment tool, most diabetic patients don't need to be on aspirin for primary prevention of complications related to heart disease. So these complications that I mentioned earlier could be microvascular, affecting the eye, the kidney, and the nerves, or it can be macrovascular, affecting the brain, the heart, and the extremities. I'll leave this slide up for you all to look at. Any questions about this slide? We are seeing how diabetes can impact a number of levels. And you would understand why when we examine a patient, like for neuropathy, we want to test temperature, vibration, soft touch as part of your neurological exam of the lower limbs, right? Kidneys, you want to screen for microalbuminuria using your spot albumin to creatinine estimation. Eye, they need to have yearly fundoscopy, so they need to have the eyes dilated and looked at by an ophthalmologist. All right. You all know what tuning fork we use to check for vibration sense? Yep, right, that's correct. A 128 hertz, not the 512, not the 256. All right. So we need to do that as part of our initial evaluation, and thereafter to pick up for neuropathy and so on. Nephropathy, back to this, the damage to the kidneys. Albuminuria is the earliest manifestation of nephropathy. So we start to lose albumin in our urine. And how do we screen for this? So we could either measure the urinary albumin creatinine ratio, or we could do a 24-hour collection of urine and try to quantify how much protein is in it, or we could do a time collection of urine for microalbumin. So we could tell the patient, collect urine for a certain amount of hours, bring it to the lab, and assess the amount of microalbumin in it. I tend to find that this spot urinary albumin creatinine ratio tends to be most useful because it allows the patient to just pass some urine in the office or the lab and get an estimation there and then, as opposed to a timed 24-hour collection. Right, treatment for microalbuminuria, because we know that this can lead to frank nephropathy and chronic kidney disease later on. We'd want to protect the kidneys by placing the patient on an ACE inhibitor or angiotensin receptor blocker. We'd want to aim for tight blood pressure control, often in the region of 125/75, or at least 130/80, not more than that. We want to achieve tight glycemic control for, as evidenced by A1C less than 6.5%, or refer for specialist care to get an opinion from a nephrologist and so on, to make sure we're on the right track towards preventing or delaying the onset of chronic kidney disease. Retinopathy, all patients with type 2 have to be referred to ophthalmologists, and they must aim for tight metabolic and blood pressure control in order to reduce the likelihood of developing diabetic retinopathy. Neuropathy, again, very important to aim for tight metabolic and blood pressure control. Smoking cessation if they are smoking, self-examination of their feet for things like ulcers, corns, calluses, nail changes, ensure that they're wearing the correct shoes and not wearing shoes that might be improperly sized so that they don't contribute to ulcers and so on. Check for peripheral vascular disease by assessing your pulses, the dorsalis pedis and posterior tibialis in particular. Test for neuropathy with your 128 hertz vibration tuning fork. And of course, sometimes center podiatrists were required to advise on proper foot care and treatment of ulcers. Macrovascular disease really relates to, as we saw in the previous slide, cerebrovascular disease, coronary artery disease, and peripheral artery disease. And this can really be negated by or minimized by making sure that the patient doesn't smoke or stop smoking, ensuring adequate blood pressure control of cholesterol and other lipid levels, and achieving glycemic control. Gestational diabetes, just a style, as I said, this is diabetes that becomes apparent in pregnancy and wasn't apparent before, and is diagnosed usually in the second or third trimester, right? So you'd find that you'd have a screening test being done in the first trimester for your blood sugar, and then patients at high risk will be retested at 28 weeks. And the way we diagnose it basically is by using this criteria that we apply also for the oral glucose tolerance tests. But bear in mind the numbers are a bit different. So if we take a fasting plasma glucose, if it is greater than or equal to 92, that is suggestive of gestational diabetes. If after they've consumed a 75-gram glucose load and their 2-hour is greater than or equal to 153, that is also diagnostic of diabetes. All right, so the OGTT test is just modified with different cutoff points here to be able to diagnose gestational diabetes. And the importance of gestational diabetes is that it needs to be picked up early on to reduce maternal and fetal complications that can ensue. And what we also know is that if you are diagnosed as gestational diabetic, then you are at increased risk for developing type 2 diabetes thereafter. And therefore, these patients need to be screened and followed up a bit more closely. So just bear in mind that the cutoff points values are a bit different when you're testing for gestational diabetes as opposed to regular type 2 diabetes. So where are we in Trinidad? So some people have tried, investigators, to look at the current standards of primary care of diabetes to see if we are meeting the recommendations. So Professor Pinto-Pereira in 2009 sought to examine if the current standards of primary care of diabetes meet with the guideline recommendations in Trinidad. And some medical students 10 years ago looked at the assessment of treatment goals attained by patients according to guidelines for diabetes management in health centers in North Trinidad. And what they found is that, well, Pinto-Pereira et al., they followed up 646 patients during this period here. And they found some astonishing findings. Waist circumference and BMI wasn't measured at any time. A1C was infrequently measured, just about 1.6 to 7% of times over the 12 months. Information on the family history was recorded, smoking and alcohol status, exercise, socioeconomic and education, and fasting blood sugar was documented. But lipid profile was only done on about half the patients, and only about a third of the patients had a serum creatinine measured. At the follow-up, patients who only advised on compliance 47.2% of the times, on diet 34% of the times, on exercise 80%. And only a fraction of them had home monitoring of their blood glucose, 0.3%. Peripheral sensations, pedal pulses were just measured 6% of the times, visual acuity 3.3% of the time, fundoscopy 12%, and ECG. These were very scarcely examined at the annual visits. So a lot of improvements required in terms of what needs to be done at follow-up visits, and in terms of information that is required at the initial visit being deficient. Moran et al., he looked at 225 patients from 5 primary care centers during this period, and only a half of them had achieved target total cholesterol. Just over half had A1Cs less than 6.5%, less than half attaining their blood pressure target. A quarter of them had a BMI less than 25, suggesting that a 3/4 of them were overweight or obese. 40% of males and 2% of females were within the recommended limits of waist circumference, so the majority of them having excessive waist circumferences. Only a fraction had 20 minutes or more of at least moderate daily exercises, and no patient met all the parameters or all the targets for these 6 parameters. So we have fallen short when last they checked a few years ago in terms of achieving target control for blood sugar, as well as for the other components like blood pressure and cholesterol. And why I think we are falling short of these best practice guidelines is that the physicians are not doing what they're supposed to be doing. You all have any thoughts about it? Why I think we aren't getting the levels of control that we would want to see in our health centers? I know you all haven't been able to get to the health centers yet, but any thoughts? The Trinidad diet, right? Okay, so yes. So it could be that the patients are not choosing a healthy diet, and therefore consuming highly caloric foods. Compliance, yes, sometimes an issue, especially because of side effects or fear of side effects or availability and accessibility of the medications. Lack of consistency among clinical practitioners. All right. Patients might find it difficult to start exercising. Yes, some people make excuses for not being able to exercise. KFC is cheap, Darren, say decreased follow-up. Yes, or maybe because they have so many patients that the frequency at which they're being followed up might not be as frequent as we want. And so they're given long appointments, sedentary lifestyles, time, yes, they do have the time to prepare healthier meals, right? So more than likely is due to these reasons here that some of which you describe. Sometimes the personnel, the number of physicians to patients may not be sufficient. So you might have 1 or 2 doctors having to see a large number of patients and therefore not being able to spend quality time to go through the full gamut of would have listed, right? Sometimes the facilities, not only infrastructure, doesn't allow for timely relay of results like A1C measures. So we might have stockouts of reagent, or we just don't have sufficient staff to do blood tests as indicated according to best practice guidelines. Sometimes, we have information gaps, missing notes, so we are unable to correlate or to review all notes and confirm the medical histories, and they have gaps in the knowledge there. Sometimes referral systems are choked up, and so when we refer to the nephrologist or to the endocrinologist for difficult cases, that they don't get timely appointments, and so the outcomes could be far from what is desired. All right, so we have some systemic issues, but what we should endeavor to achieve is that they ought not to be due to a lack of knowledge of the physicians, We should know what is best practice and should be able to adhere to those standards to the best of our ability to achieve the outcomes we're looking to achieve, right? So these are some of the reasons why we haven't been achieving it, and we need to do better. So I wanted to share with you all a video here about the ABCs of the. Let's spend some time looking at it, and we can discuss it first briefly afterwards.
For my patients with diabetes, I like to introduce the concept of ABC times 2. So the first ABC is just remembering to schedule a regular visit with your clinic every 3 to 4 months, where we can review how you're doing over time. In our clinic, we use a stoplight approach, giving you a green, amber, or red light on your different ABCs. This is so important as we need to measure you so that we can tweak your medications or lifestyle to improve your chances of staying healthy. So in ABC number 1, A stands for A1C, which is a test that looks at your control of blood sugar over the last.
All right, so some people say they can't see. I'm not too sure why it's showing on my screen. Let me try again. All right. Okay.
For my patients with diabetes, I like to introduce the concept of ABC times 2. For my patients with diabetes, I like For my patients with diabetes, I like to introduce the concept of ABC times 2. So the first ABC is just remembering to schedule a regular visit with your clinic every 3 to 4 months, where we can review how you're doing over time. In our clinic, we use a stoplight approach, giving you a green, amber, or red light on your different ABCs. This is so important as we need to measure you so that we can tweak your medications or lifestyle to improve your chances of staying.
All right, so you're seeing this right now? What slide you're seeing now? This one, requirements for the effective delivery of care? Yeah, all right, okay, I'm gonna try, let's try one more time.
For my patients with diabetes, I like to introduce the concept of ABC times 2. So the first ABC is just remembering to schedule a regular visit with your clinic every 3 to 4 months, where we can review how you're doing over time. In our clinic, we use a stoplight approach.
Okay, let me see if I can post the link on the chat here.
Giving you a green, amber, or red light on your different ABCs. This is so important as we need to measure you so that we can tweak your medications or lifestyle to improve your chances of staying healthy. So in ABC number 1, A stands for A1C, which is a test that looks at your control of blood sugar over the last 3 months. B stands for blood pressure, and C stands for cholesterol. The second
All right, I think probably my internet connection dropped temporarily there, but were you all able to view? Right, so you see that different practitioners come up with innovative ways, you see, for being able to remember how to advise their patients or make it easy for patients to come to terms of what is required for them. A, B, C, right? So you saw in this patient, A was what? A was hemoglobin A1C, and B was their belly or the abdominal weight, which is a big risk factor, especially among certain ethnic groups for insulin resistance and subsequent diabetes. And C is to be an agent of change, right? To change your lifestyle in order to promote and protect your health and improve your blood sugar. All right. So basically, students, with a lot of information, it's impossible for me to cover the whole topic of diabetes, especially therapy part of it. So I want you to take away from this that guidelines for us exist locally, and the CHRC has guidelines, CARFA that is now, but theirs hasn't been updated for a long time. And so you'd find that most local people would tend to go with established international guidelines like the ADA, American Diabetes Association. So I wanted to review those slides, and we also need these resources to more effectively translate these guidelines into best practice in our primary care system. When you do, God willing, be able to go into the health centers, you'll find that a large number of them don't get the sort of control that we would like. And the reasons for that are quite complex. And sometimes it could be systemic issues because of the large clinic numbers, the infrastructure, absence of reagents, and so on. But sometimes it could be due to the fact that the clinician hasn't taken the time out to explore the illness experience, to inquire about compliance, side effects, fear of side effects, or hasn't followed through in terms of what is required from the history, examination, investigations requirements to be able to pick up the parameters that need to be sorted out to help achieve glycemic control. So I want you to think of diabetes in the context of the metabolic syndrome, not in isolation. I want you to recall that metformin and lifestyle changes are what is first line, and there are a number of other agents that can be selected based on your desire to control costs, minimize weight gain, or minimize hypoglycemia. And in certain groups, like those with established chronic kidney disease and cardiovascular disease, there may be one or two agents that are preferable in comparison to the others. All right. These are some references here. Any questions, comments about diabetes? I know it's a lot for you all to take in this morning. I'll take questions now. All right, Daniela is asking, do we assess and manage a diabetic foot in primary care or only for the secondary care? No, certainly, Daniela. Yes, sir, I should say we do, as part of our evaluation, routinely check our patient's feet. And if it is that the foot problem is one that can be sorted out within primary care in terms of an ulcer that requires dressing or prescription of antibiotics for infection and so on, we do offer that service. There are certain clinics in Trinidad, I think El Socorro Health Center, that has a specialized diabetic foot care clinic run by a podiatrist, but it's not commonplace throughout the country. But there are resources within primary care to treat with it, and referral is only for complicated cases or cases where it's proven refractory to treatment in primary care, or there may be, complications like gangrene and so on that require amputation. Right. Okay, guys. So I think tomorrow you have lectures with Dr. Motilal, some communication skills lectures. I'll post the recording for this a bit later on today. You have your forum post to work on. We are at present trying to get the clinical vignettes that you would be required to use when writing up your long case. I'll give some specific instructions about how to go about it when we give those long cases individually. And we're trying to do so this week. But essentially, what we want you all to do based on the clinical vignette that we would give each of you is to come up with a list of differential diagnoses and discuss the management of the most likely diagnosis from an evidence-based perspective with references and so on. And you probably will be required to run it through Turnitin, which is available on eMyLearning to avoid plagiarism and so on. And that one will be due at the end of the rotation. We probably give you until the Sunday after the clerkship ends to be able to submit that long case. So we hope to be able to assign that this week. And we hope to be able to post all the lectures this week. We're just waiting on Professor Maraj's lecture, which will also be done asynchronously. And that will be posted hopefully by Wednesday. So you can view that at your own time. And not necessarily when it is indicated on the schedule. All right, Nirvana sent you an email from Ms. Patterson, so there's an update there. So perhaps you can share it with the students that are having difficulties with MyLearning. And I know Dr. Motilal would have shared the link to the EBM assignment for those of you that couldn't access it, because I know you have a time frame in which to complete that assignment. All right, so students, if no questions, I'll post this recording sometime later today, and I look forward to receiving your replies and keep them coming. Remember, anybody could respond to the forums once the assigned person has responded first, and the purpose is to generate discussion. I don't really care if you're right or wrong in your view, once is something that that is reasonable, and we can generate some discussion arising out of it. All right. All right, so I'll end the session now and post the recordings later on. See you guys.